All right, we will kick it off. Hello, and everyone. Thank you for joining us. My name is Ruthie Marker. I'm the Education Program Manager at the Allergy and Asthma Network. I'm delighted to welcome you to this afternoon's CME accredited webinar. We have a special presentation today focusing on mental health and how it plays a role in asthma management. Before we start today's program, I'd like to cover a few housekeeping details. Everyone will remain on mute during the webinar to minimize any distractions. We will record the session today and upload it to our website in about a week. You can watch all of our recorded webinars at allergyasthmanetwork.org. Our webinar is scheduled to last 1 hour. There will be time at the end for question and answers, so please feel free to submit those at any time through the Q&A box located at the bottom of your screen. One of our team members will be monitoring the chat for any questions or help you might need, and we'll do our best to answer all the questions at the end before we wrap up. This Advances webinar is brought to you in collaboration with the American College of Allergy, Asthma, and Immunology. The college offers continuing medical education credits for physicians and attendance credits for all others. You can create a free ACAI account to earn CMEs or attendance credits for all of our Advances webinars through their member portal. All attendees will receive a certificate of attendance. Please note that no additional continuing education credits will be provided. A few days after the webinar, you will receive an email from Zoom with supplemental resources that mirror the content that we talked about today, and also to download your certificate of attendance. Today's presentation is titled Depression and Anxiety in Patients with Asthma. As clinicians, we know asthma management goes beyond inhalers and action plans. Mental health, particularly depression and anxiety, can significantly influence asthma control, adherence, outcomes, and most importantly, our patients' quality of life. Today's presentation recognizes that treating asthma effectively means caring for the whole patient. With us today is Dr. Todd Marr, who is an allergist and immunologist at Amplify Health by Gunderson in La Crosse, Wisconsin, and serves as an adjunct clinical professor of pediatrics at the University of Wisconsin School of Medicine and Public Health. He is the past president and current executive medical director of the American College of Allergy, Asthma, and Immunology. He has received multiple distinguished service awards and has held leadership roles with the CDC-funded Wisconsin Asthma Coalition, the NIH All of Us Research Program, and the American Lung Association American Academy of Pediatrics. In addition to his clinical and public health leadership roles, Dr. Marr has been active in the local mental health awareness community with his wife and son for the past 17 years in memory of his daughter, Caitlin, who suffered from depression and bipolar disorder. He helped co-create Caitlin's Table for adolescent mental health locally. Thank you again for being here, Dr. Marr. I will turn it over to you.
Thank you, Ruthie, and I want to thank everybody for being online. We'll go ahead and start here with disclosures. And basically, I do have some conflicts here, but none of these are going to impact whatsoever on what we're going to talk about at all. So that being said, here's our learning objectives. We're going to understand the association between asthma and behavioral health issues. We'll talk about the presence of anxiety and depression in asthma and how it's associated with negative asthma outcomes. And we'll recognize that anxiety, depression, and asthma can be treated. That being said, as Ruthie mentioned, I got active and more involved in this from the mental health standpoint with Caitlin's passing. So this is a reprint from our local La Crosse Tribune article and talks about Caitlin. You can look at this while I talk a little bit. This was Caitlin. Caitlin passed away on November 19th, 2007. She had depression, she was bipolar, and she died of a prescription drug overdose while at college. She was only 20, and this really impacted her life, to say the least here. We kind of dug ourselves out from the grief and basically looked at what we could do next. In her obituary, we actually put that Katie lost her battle with depression and died of an accidental overdose. The process of doing that brought so many people out of the woodwork to talk to us afterwards, saying, thank you for being upfront. Thank you for bringing this out into the light of day. And it was our first step of many to help others in telling Caitlin's story. And we wanted to help. I wrote a grant through the American Academy of Pediatrics for a catch planning grant and then an implementation grant to look at moving mental health out of basically the clinic and into the community. We helped support our local Y Teen Center getting up and running. And Kaylee was at Lawrence University when she passed away, and we've supported behavioral health programs there for adolescents and young adults attending college. Locally, I was involved with Change Direction and the national launch of that with Michelle Obama in Washington. I told Caitlin's story there. And so that kind of led us down the path of having Caitlin's Table, which we've endowed here locally, and we support adolescent and young adult mental health. And with that, then, that leads me into asthma. Katie did not have bad asthma. She had mild asthma. The rest of us have asthma and allergies. But overall, what is health? So let's start there. So health is really a state of complete physical, mental, and social well-being. It's just not the absence of disease or infirmity. That's the World Health Organization. You can't attain it or maintain it by pills or procedures. It really is an initiation and maintenance of this homeostasis that we need to look at. There are a lot of non-physical components. Our outlook on life, there's the physician-patient relationship, that's the entire healthcare team. And there's also the relationships between our spirituality and health. We're going to be talking about anxiety and depression. Anxiety is the mental condition characterized by excessive apprehensiveness about real or perceived threats that lead to avoidance behaviors. People will not want to go out in public. They'll want to avoid certain instances where they might be placed into conflict. They will obtain lack of comfort by having increased heart rate and muscle tension. And there's three main characteristics. There's the emotional, that's that general feeling of tension. There's the physiologic, such as the muscle tension, the sweating, the fast breathing, or feeling of that chest tightness that people have. And then there's this impairment or cognitive. People will talk about them having brain fog and thought storms and disordered thinking. Depression is a little bit more intense. Depression or major depressive disorder is common. It's a serious mental disorder that negatively affects how you think, you act, and feel, and how you actually perceive the whole world, in all honesty. Almost a third of all adults have been diagnosed with depression at some point in their lives, and about 18% are currently experiencing depression. That's a 2023 survey. Women are more likely than men, and younger adults are more likely than older adults to experience depression. It can occur at any time or any age. The average of its first appearance is during one's late teens or mid-20s, and that's what we saw with Caitlin. So what are the symptoms that we see of depression? So they can vary from very mild to extreme severe depression, and can be different in each person and different in each person in stages. But generally, we think of it as feeling sad, irritable, empty, hopeless, losing interest or pleasure in activities that usually people had enjoyed in the past. They can have a significant change in appetite. They can eat much less, or they can eat more than usual. They can have weight loss or weight gain. They can sleep too little, or they can sleep too much. So you can see that it's not one thing. They generally have decreased energy or increased tiredness and fatigue. They don't generally have increased energy and, rambunctiousness that way. There is an increase in purposeless physical activity. So the inability to sit still, they're going to be pacing, hand-wringing, or slowed movements or speech. Generally, when it gets worse, they get this feeling of worthlessness, of excessive guilt. They have difficulty thinking or concentrating and have increased forgetfulness. And then to the extreme, thoughts of death or suicidal ideation or suicide attempts can be part of depression symptoms. So where are we in the Western society? So major health challenges we have here, we talk about chronic diseases. We talk that they're increasing. They've doubled between 1985 and 2005. Hypertension, cardiovascular disease, diabetes, metabolic syndrome, cancer, and allergy and asthma. But almost all chronic diseases have an inflammatory immune component. And we're going to talk about that today. We are an increasingly obese and sedentary society, unfortunately. And wow, there's an increasing level of societal stress. We're seeing that right now, both from the economic standpoint, the environmental standpoint, COVID pandemic, and right now in the winter with all of the COVID and flu and RSV and everything going around. And then a huge philosophical adversarial stressor. basically we no longer agree to disagree. We take sides, and that has definitely had an impact, at least here in the United States. Western medicine is increasingly technologically driven. The psychosomatic illness is often trivialized or ignored, but a lot of people have that. And we minimize the whole person, and we want to just treat individual systems rather than the body and the mind and the spirit. So does the mind affect our immune system? Is really a question that's been asked for a long time. And indeed it does. And going forward, we're going to talk a little bit about the hypothalamic pituitary adrenal system, the HPA axis. This is communication between basically the pituitary gland and other three organ systems there that have this endocrine system feedback. And it's a loop of hormones that enact and regulate your body's stress. I'll talk about this more specifically. And it's the neuroendocrine system. The autonomic nervous system has two components. There's a sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system functions like a gas pedal in the car. It triggers fight or flight response, providing the body with a burst of energy so it can really avoid or respond to perceived dangers. So a stress response is not just an event, it's a stress response. So the event is the stressor. The response is something totally different. The psychological response to an event can be acute. I'm under a lot of stress. That could be the fight or flight response we just talked about. It's a combination of the HPA axis and the autonomic nervous system with rapid resolution. It usually is helpful and healthful. It's exercise, it's emotional excitement. But excessive or chronic types of stress, I'm stressed out, can lead to anxiety and depression and over worrying and things. This is this endocrine immune exhaustion that some people think about. It's maladaptive. And there's major factors that can impact this, okay? Both impact how it presents, impact how strong it is, and how long it lasts. So one is the outlook, our optimism versus pessimism. Some people are very optimistic, some are very pessimistic. Other impacts are our social support system, having a nuclear family, having a fraternal organization, having a community. And then our belief system, our spirituality. I know personally when we went through this back in 2007 with Katie's passing, I had my family. I have 4 brothers. I have mom and dad. I had a very close family that helped. But I also had my community. I had the College of Allergy because I was just basically coming off being on the board for the college at the time. And I was involved in a lot of other organizations, and just seeing the support I got from those friends, which really became a strong community for me and for my work here at the health system I work at. They basically gave me great assistance and help. And so that's what some people just don't have that. And I was lucky to have it. So our neuroimmune endocrine interactions are kind of schematically drawn out here. And we'll show this in another slide here a little bit better. But there's the stressor, upper left, that I talked about. And then there's that perception of the stress. And then there's that pituitary adrenal axis that kicks in. And that can produce epinephrine and cortisol and norepinephrine. And then that sensory nervous system impacts on it. So there's antigen-presenting cells that can get stimulated, and through the release of cytokines and chemokines and cell activation, these immune cells have an altered immune balance, increased immune exhaustion, and increased inflammatory response. Another way of looking at it is on this slide. You can have a short-term stressor, which could be immunoprotective in the middle there. Is this short-term stress experienced during vaccination or wounds, infections or cancer? It could be beneficial. It could increase the effectiveness of vaccinations and wound healing and increase resistance. However, if it's an acute stress that's more intense, an innocuous antigen and allergen-induced, there might be some harmful or pro-inflammatory or autoimmune disease that comes from that. Similarly, with a chronic or a long-term stress. With that can be increased dysregulation, pro-inflammatory cells, type 2 cytokine-driven responses. We see that. And then there is the increased immunosuppression that can come with this chronic stress. Decreased lymphocyte numbers, suppresses leukocyte functioning, mobilizes immunosuppressive mechanisms, the regulatory T cells. And that can lead to decreased efficacy of the vaccination itself, decreased wound healing, decreased resistance to infection and cancer, and some decrease in pro-inflammatory and autoimmune disease, but that's really a side stream effect from that. So I'm going to go through a number of slides that talk about some various studies. I'm not going to get into all the studies and what they did. I just want to kind of lay the groundwork for you of how all of this kind of works from that standpoint. So in this study that was published in 2009, they investigated how anxiety and stressors might modulate skin prick test responses. So an interesting and fascinating type of study looking at, okay, simple skin prick test, which we do all the time in allergy, looking for responses in people with allergic rhinitis. They had 28 men and women with allergic rhinitis. They had skin test responses. They studied them twice over 4 hours in a crossover design. And they looked at the skin prick test wheels from 6 allergen panels that were assessed before and then after a social stress test. Okay. And then the next morning they looked at it. And they looked at the wheel diameters and minus the saline skin prick test. So that was their control. And they averaged them. And what they really found is that anxiety heightened the magnitude of the allergen-induced wheels following the stressor. As anxiety increased, the skin prick test wheel diameters increased after the stressor compared to a slight decrease following the control task. And that anxiety also substantially enhanced the effects of the stress on the late phase response. So even skin tests performed the day after the stressor reflected the continuing impact of that speech stressor that they used to make those people anxious. So very interesting study looking at something that we would have thought, really, what effect can that have? So can stress worsen existing mast cell diseases? So we're dealing with asthma and other allergies. So yes, there's been studies out there. This is a study titled The Psychological Distress and Maladaptive Coping Styles in Patients with Severe versus Moderate Asthma. So they basically looked at 84 patients. Half of them were women, about age 46 on average. About half of them were severe, half were moderate. They looked at the time using the American Thoracic Society criteria, because this was back in 2010. They did demographics and medical history reviews, pulmonary function, and allergy testing. And then they did basically a behavioral medicine diagnostic inventory that looked at psychological distress and emotional behavior coping factors and all of that stuff. And not meant to be looked at intensely, but what you can see is highlighted those that had a positive p-value. And what they showed in the first column is severe asthma, and the second column is moderate asthma. And you can see that they showed a significant difference in severe versus moderate in anxiety and tension, in cognitive dysfunction, in illness apprehension, in pain sensitivity, in future pessimism from the scale that they used, in spiritual absence went down, and interventional fragility. And then they found behavioral coping styles that these patients with severe asthma had basically in significantly greater functional deficits and problematic compliance. So intriguing that both sets of patients had asthma, but the severity versus moderate, there were differences. So what we know is that ACEs, or adverse childhood experiences, and chronic and toxic stress play a role on the HPA axis activation. Cortisol's increased. There's a Th1, Th2 imbalance that can have an impact on ATP, or atopic march. There's alteration in glucocorticoid receptor expression, and that can lead to an altered response to inhaled steroids or anti-inflammatory agents, and an altered response to bronchodilator agents. This is a study done in 2020. So in another study, they looked at brain-derived neurotropic factor levels in patients with depressive symptoms who had asthma. So serum brain-derived neurotrophic factor levels are positively associated with both depressive symptoms and asthma severity in patients with asthma. This was published just last year in 2025. So they speculated is the findings suggest that the mechanisms underlying depressive symptoms in patients with asthma may differ from those in major depression in the effect of this in respect to the serum brain-derived neurotrophic factor. So they suggest that biologic mechanisms underlying depressive symptoms in asthma might be different than those in major depressive disorder. So it may not all be the same thing. In another study that came out in 2018, they looked at allergic disorders and the risk of depression. So this was a large review and meta-analysis of 51 large-scale studies. And so they reviewed all of them and did a forest plot here. And again, you're not going to read all of it, but at least what you can see is the conclusion was the result of the study showed that allergic disorders significantly increase the risk of depression. Patients with allergic disorders, asthma, allergic rhinitis, were 1.5 times more likely to have a comorbidity of depression compared to controls without allergic disorders. So all these are individual studies, and the relative risk The forest plots, you can see those to the right were more likely to show that there was an influence on it. So in the association between asthma and depression is well described, but it really we're just beginning to understand it a little bit. In another study by Fuki, they showed that a third of adults diagnosed with asthma also experienced signs of depression. So the presence of depression in these patients was linked with adverse asthma outcomes, which was manifested with increased visits to the ED and urgent care facilities. In a World Health Survey, they reported that the occurrence of depression associated with asthma can exceed 50%, while anxiety can be as high as 80%. So as clinicians and healthcare providers, we need to be aware of this when we're talking with our patients with asthma. And there was a report from cross-sectional data from the NHANES study that linked depression, but not anxiety, with a reduced bronchodilator response in adults with asthma, which is what we just talked about, that you could see that decreased bronchodilator response. So a few more studies. This is a comprehensive review of the intersection between asthma and depression that was published just a couple of years ago. This again was a rigorous PubMed search. They used the terms asthma and depression. Papers were screened by the authors in view of their eligibility. What they found was that there was a correlation between the conditions. Okay, they presented preclinical and clinical research data, and the evidence presented supports the existence of a correlation between asthma and depression. By acknowledging these shared biologic mechanisms, genetic factors, and epidemiologic trends, we can formulate more efficacious strategies for addressing the dual impact of asthma and depression. So again, leading us down that path that we need to be thinking about this when we're seeing patients and treating patients. This again was another recent study just last year that looked at 31,000 participants from the NHANES study in the US and about 17,000 participants from ELSA, which is the English equivalent. This is observational research, and patients who had depression and had a significant increased risk of asthma in comparison with participants without depression. So again, these further substantiate that genetically predicted causality of depression on asthma, while the reverse causality doesn't stand. So asthma really doesn't cause depression. These findings indicate that depression may play a contributory role in the development of asthma, underscoring the potential benefit of implementing preventive strategies aimed at managing depression and mitigating asthma risk. And this is just a recent study this year that came out of BMC Medicine that basically looked at using the All of Us research program. I've vested interest in this. I'm one of the PIs on this in recruiting patients here in Wisconsin. It's a large database that initially was set up to try and get 1 million people to basically lend their EMR data and do some baseline history and intake through questionnaires, and then give samples for genome analysis. And they looked at a section of these, and they had 88,000 patients with asthma and about 450,000 controls. They had 412,000 patients with depression and 1.5 million controls in this cross-sectional analysis. And they looked at the genetic predisposition and showing that it contributes to asthma depression comorbidity through direct effects and shared pathogenic processes. Again, they highlight the potential to develop targeted interventions to prevent and treat this co-occurrence of respiratory and neuropsychiatric disorders. So something, again, we should be on the lookout for. So what do we know about it? What are we doing about it? Well, there's been some publications out there. Perla Vargas published this in Jackie in Practice back in 2019 and 2020 with an editorial looking at the comorbidity of asthma and depression. It's not a product of vulnerable personality. That's just something we should be aware of. And what they looked at is the prevalence of multiple morbidities increasing significantly from 85 to 2005, which you talked about at the beginning. Prevalence in individuals with 2, 3, or 4 more diseases rising by 20, 60, and 300% respectively. So we're struggling with more and more comorbidities in a lot of patients. By 2010, 31% of all Americans had multiple chronic conditions. So the presence of a mental health disorder, depression was the one that was most common, appears to increase as the number of medical morbidities increases. From 2001 to 2003, the National Comorbidity Survey of 34 million American adults, and about 17% of the adult population had a comorbid mental and medical condition. Specifically, asthma patients have a higher prevalence of anxiety and depression, than does the general population. So compared to those without asthma, individuals with asthma are approximately twice as likely to suffer from depressive disorders and 3 times more likely to suffer from anxiety disorders. So this increases the risk for poor adherence, one of the things we're always battling in asthma management, to lifestyle changes, allergen avoidance, impairing functioning, and increasing healthcare utilization, which can further worsen asthma control. Again, in Jackie 2018, this was anxiety, depression, and asthma control changes after standardized treatment. So what they did is they enrolled over 3,000 patients with moderate severe asthma. They looked at the asthma control test, they did spirometry, they did hospital anxiety and depression scale at baseline and at 6 months. And then the treatments were decided by specialists. And they wanted to examine the association of asthma diagnosis and then symptoms of depression, anxiety, and the asthma control, not just at baseline, but over this 6-month period. And what they showed is that at baseline, 24.2% and 12% of patients were diagnosed with anxiety, 24% depression, 12% respectively. And after 6 months, anxiety and depression improved, went down to 15%, 24 to 15%, and then 12% to 8%. Okay. Mean FEV1 and asthma control improved. Asthma control test went from 15.8 to 19.4, so that was significant. So patients with anxiety and depression used significantly more healthcare resources and had more exacerbations. They showed that patients with anxiety, depression, and the lower FEV1 were independently associated with poor asthma control. I think we all could have probably guessed that to begin with, but it really showed that there was nearly a 4-fold greater influence over asthma control than depression. So standardized asthma care, after specific visits with a specialist, patients present significant improvement in these psychological disorders and exhibit better asthma control and functional parameters. So we need to treat the whole person. We need to do more than just giving them their asthma medicine. And here again is something very similar done. This was Jackie in practice back in 2021, looking at a multivariate associative child depression and anxiety. So these results suggest that psychiatric symptoms, especially anxiety, are associated with poor asthma-related quality of life, have a more negative perception of asthma control in girls compared to boys. Okay? Clinicians should consider incorporating questions about psychiatric symptoms as part of their routine asthma management and focus patient education on the unique differences maybe in boys and girls in this childhood population. This was published in Annals and looked at impact of anxiety and depression on outpatients with asthma. And basically what this looked at was anxiety and depression, as we've talked about, are in patients with asthma, but a lot of findings conflict at times. So they wanted to investigate the effect of anxiety and depression in a group of outpatients with asthma. They looked at 263 patients with asthma. They did, again, clinical exam, lung function, FeNO, so fractionated exhale nitric oxide measurements were done, asthma control tests, asthma control grade, perception of symptoms on a visual analog scale, and that hospital anxiety and depression. And they found that globally, 36.9% of patients had anxiety and 11% had depression. 71 had combined anxiety and depression, and that anxiety and depression were associated with poor asthma control. Patients with depression had higher body mass indices, so they were eating more and had higher body mass indexes, and anxiety and depression were associated with lower ACT scores. So this is a real-life study indicating that anxiety and depression are common and relevant comorbidities in asthmatic outpatients that we're going to see and can be associated with uncontrolled asthma and lower ACT scores. So if we're seeing patients back in clinic and we're following an ACT score, or we're following their spirometry and looking at their overall asthma control, if their asthma control is not great, we really should be thinking about comorbid mental health disorders and be looking at those. This was followed up with a presentation in 2024 about these treatable traits in asthma. It was an excellent article that was published and looked at a variety of different treatable traits. And one of those was anxiety and depression. Okay, and so they looked at prevalence of anxiety and depression in people with asthma and showed anxiety, again, 24 to 38%, depression about 10 to 25%. What were the adverse clinical consequences associated with that? Poor asthma control, reduced health-related quality of life, and frequent asthma exacerbations. They also looked at how to recognize anxiety and depression. And they found that the best thing you could do in your clinic was using questionnaires, and that you should have treatment options. So psychological, pharmacotherapy, lifestyle, and social interventions. That doesn't mean you as an individual clinician or provider, but your healthcare team should be looking at what can we do to look at these trait identification markers and these treatable traits. They did come up basically with an asthma, depression, and severe asthma poster that you can download. This was actually from Australia. And I'll highlight some areas in this because this might be hard for you to read, but it talks about what is anxiety. Okay, ongoing or disproportionately strong fear, worry, or stress, and avoidance of situation that cause fear or worry. What is depression? Ongoing symptoms of sadness, emptiness, irritability. And they talk about asthma, anxiety, and depression impair a person's ability to function in their lives and often occur together. That anxiety is 1.4 times and depression 3.3 times more common in people with severe asthma compared to non-severe asthma. Okay, and that they're more common in people with asthma, and that can lead to reduced asthma control, impaired quality of life, reduced lung function, impaired functional outcome, and increased healthcare utilization. The bottom half of the poster then talks about the percentage of severe asthma population, 38% with anxiety, 25% with depression. But there's some screening and referral, self-reported questionnaires, that hospital anxiety and depression scale, the HAD score. There's the Kessler psychological stress. There's the 2-questionnaire or 3-questionnaire asthma depression score you can use, excluding dysfunctional breathing as an alternative diagnosis, referral for a psychologist or psychiatrist, and then management options. Mental health problems in asthma are undertreated, and options incur some lifestyle changes, some pharmacologic interventions, some psychological interventions, counseling, CBT, and then social support. So this again is from severeasthma.org in Australia. And then basically, this was a scoping review in 2022 that examined existing interventional therapies addressing depression, anxiety in people with asthma specifically. They looked at pharmacologic interventions, they looked at psychological and lifestyle and complementary and alternative medicine. And they came up with basically some highlights of the paucity of the randomized trials, unfortunately, to treat all of this. And they came up with an infographic summarizing asthma and depression. So I'm showing you this so you can actually go get this and maybe have this in your clinic. This is blown up here, just so you can see it better. So biologically, they talk about selective serotonin reuptake inhibitors, SSRIs, and tricyclic or other antidepressants can be used. The benzodiazepine short-term, and then ECT therapy and transcranial magnetic stimulation is becoming popular. Psychologically, cognitive behavioral therapy, I already mentioned, interpersonal therapy, acceptance and commitment therapy, mindfulness itself, relaxation therapy, and exposure therapy. Socially, getting that support from family and friends. Having family education and caregiver support is important. Being involved with support groups, community participation in employment and housing. And then the lifestyle changes you can make: exercising, eating more healthy, weight loss, good sleep hygiene, trying to maximize that sleep and make it be good sleep, and then decrease other substance abuse like smoking, alcohol, and other drug cessation or management. So I think what we have to look at is other things that can be seen as other impacts. So when we look at this, signs of depression linked to monoclonal antibody therapy, non-response in patients with severe asthma was looked at. This is a small single center study from Germany. They used questionnaire screening for major depressive disorders or general anxiety disorder. And they found that patients that respond to monoclonal antibody therapy exhibited lower levels of major depressive disorders or general anxiety disorders related symptoms, and the prevalence and probable MDD and GAD decreased significantly after initiation of the monoclonal antibody therapy. So improving their asthma helped their major depressive disorders and their general anxiety depression. So logistic regression analysis revealed pre-existing symptoms of depression were a major predictor for some non-response if they were pretty significant. So we have to keep that in mind, that maybe we need to improve their depressive symptoms and anxiety symptoms before we expect monoclonal antibodies to work in patients with severe asthma. So what can we do in an allergist's office? So this was published, an article published in Annals back in 2020. and came with some behavioral health symptoms at the start of the appointment. What can we do? Well, we'll evaluate behavioral health symptoms. Due to limited time commitments, we have to have these be brief, reliable, and valid questionnaires. There's a number of them out there. There's the 21-item depression, anxiety, stress scale. There's basically assessing severity of anxiety, depression, and stress within the past 2 weeks. This measure has a strong psychometric properties. It takes only a few minutes to complete, and it's at the third grade reading level. It provides clinical cutoffs, allows healthcare providers to quickly classify patient symptoms as normal, mild, moderate, severe, extremely severe, and then severe, extremely severe suggests the presence of a possible mood or anxiety disorder. So a simple tool that can be used. Results can be helpful first, given the stigma associated with behavioral health issues. Patients may be more willing to disclose their symptoms on a questionnaire than directly to the healthcare provider. So a number of studies have looked at that, where patients sitting down and filling out a questionnaire were more likely to be honest with that than with you asking them direct questions. The questionnaire opens the door for you to probe further. All right, the items on the questionnaire offers the healthcare provider a starting point to discuss these psychiatric symptoms and allows for proactive planning of treatment regimens. For example, a patient with severe depression has a greater likelihood of not adhering to treatment or may be more likely to miss appointments in the future. So knowing that allows you to do some problem solving with the patient, to identify ways to improve that adherence, setting reminders on their phone, increasing the frequency of our appointment reminders, using telehealth maybe to facilitate contact with the patient in between, or initiating a referral to behavioral health for evaluation and treatment in conjunction with your treatment of their asthma. So with that then, I went through this really quite rapidly, and I apologize for that, but I want to get through all of it. There are various factors that contribute to the connection between asthma, depression, and anxiety. And these are genetics. Can't fix that too well yet. Can't pick your parents. Development, we're working on that, but not the easiest thing to have an impact on, but being aware of it is important as we counsel patients with younger families. Basically, inflammation we talked about, and then medication effects. The main implications arise from immunomodulatory effects on the body that contribute to the increase of inflammation in the lungs. And basically, that's in conjunction with genetics, and that influences the immune system. It can suppress the body's ability to regulate an appropriate defense response, causing the body to be more susceptible to development of the illnesses concurrently. So depending on the timing of the diagnosis of asthma, the severity, their lifestyle, all of that correlates with increased likelihood of developing depression. Lifestyle changes, balanced diet, regular exercise, stress management can improve both conditions. Integrating depression screening into the patient visits is needed. So finding out what your system has and what you could use is important. Okay, some of the depression screens are copywritten and can't be used, but a lot of them out there are basically available to all of us. And then precision medicine holds promise for customized treatment plans based on genetics, lifestyle, and environment. So with that, hang on a minute. I want to leave you with something totally non-stressful, and that's my dog Angus, who basically should just calm you all right now and allow you to take just a big breath and relax and realize that, yes, anxiety and depression impact asthma. Asthma can impact anxiety and depression, and we should be looking for this in our practices. So with that, I'm going to turn it back to Ruthie and see if we have any questions.
Yes, we do. We do have lots of questions coming in, and thank you, Dr. Mar, for that presentation. Truly a topic that needs to be spoken about in every field, but especially for our asthmatic patients. So we'll start off with a question we have related to medications. So the question is, similar to cardiac and blood pressure medications, are there any concerns you have with your patients about psychiatric medications affecting asthma symptoms or vice versa?
That's a great question. Most of the psychiatric medications don't have a negative effect on asthma control. Some of the asthma medicines, if overused, can have an effect on some people with anxiety, let's say albuterol, so the short-acting bronchodilators. And having people be aware that if they happen to be somebody who's more sensitive to those, if they have beginning of a flare and they might overuse that, they might have more issues. Prednisone for some people can have an impact, but most of the depressive type medications, whether it's SSRIs, et cetera, I'm trying to think, most of them don't have too many interactions with asthma. So it's a great question, but I'd be careful on the flip side.
Okay, awesome. Should, before in your practice, should mental health evaluations be a part of the workup before you start escalating into advanced therapies for severe asthmatics?
Yeah, I mean, that is a wonderful question with that last study that we talked about out of Germany with the monoclonal antibody. Should we be looking at patients who have moderate severe asthma and we're thinking about the next step should be a monoclonal antibody at $55,000 to $80,000 a year? Or should we really take a step back and think, am I doing everything else I can for that patient from the standpoint of their mental health? And a lot of times we've not looked at that. We do get siloed, unfortunately, in our care. And as an allergist, I find that in myself a lot. We may defer all of this to primary care, but they may not be seeing their primary care provider that often. So I think it behooves us as respiratory specialists to be thinking about it, maybe do one of these screening tools and maybe say, your asthma is not controlled, but before we take the next step on that, let's start the process of maybe getting it approved. But let's see if we can get your mental health under a little bit of better stability and see if that helps. So it's a good question. I agree.
Thank you so much. We have a couple of questions regarding those screening tools. One being which seem the most practical validation tools to assess for anxiety and depression, and two-part to that is when are allergists going to be implementing those, or is it just your practice?
No, I think there's a fair number of allergists and primary care providers that are doing that. It all depends on your system. I'm at a large medical practice. Okay. So we have Epic, it's built into Epic. And so part of the depression screening is part of population health and it's built into it. So who does it? Sometimes it's a battle of whether the MA does it when they room the patient, whether somebody else should do it, do they get sent it at home? So that's the logistics of finding out where you practice. If you're on your own, this is something you can easily implement. And sometimes just that there's a two question there that, have you been feeling depressed down and second question, have you had any thoughts of harming yourself in any way? There's a number of them out there that have good validation behind them. Just find one that you feel comfortable using, that you have the time to consistently use in your practice. All right. And some people say, well, I don't want to use a validated measure. I don't want to use a questionnaire. I'm just going to ask the patients. Well, remember what the study shows is that patients generally are going to be more comfortable answering a questionnaire like that. And it opens the door for you to then basically act quicker, and not act quicker, but open the door to ask more about that. Just like the asthma control test. The asthma control test we use in our practice all the time. But it really opens the door. If I walk in the room and their asthma control test score is 17, and they tell me that they're doing great and they have no problems whatsoever, and I can say, hey, your ACT is 17. What's going on? Tell me about this. So it helps flag me that I need to ask more questions. Okay.
Right, correct. Okay, we have one question regarding montelukast. Can you speak to the side effects of that in your patients and on their mood?
Yeah, I mean, montelukast does have a black box warning for potential depressive and behavioral health effects. I think the studies have shown we're talking single digits as its effect. However, I will tell you that since that black box warning came out, and with the advancements we have in other therapies, I am more likely to not initiate it for patients who have mild asthma. And if somebody is on it, I'm going to consider that's going to be the first drug I'm going to probably take them off of if they have other therapies that are controlling the inflammation and everything else. So I'm upfront with patients. I let them know that if I'm initiated, that there's a black box warning on this drug. If you see any changes or any effects, which might occur within the first month or two of starting it, you need to be aware of it and you need to let us know. Not seen in somebody who's been on it for years and years generally. It's usually seen initially with the initiation of therapy. So keep that in mind. But if I'm taking care of a teenager is the primary place I would see it, or young adult, who basically is in that rough time period where you begin to see more of the behavioral health and mental health effects of just life in general, I'm going to be more likely to try and discontinue that than I am something else. And I hope that helps.
Yes. Oh, that's a great response to that. We have another question regarding differentiating between asthma and anxiety. The question is, how do you evaluate and assess what clinical cues help differentiate anxiety-related dyspnea versus asthma-related dyspnea?
Well, that's another good question. And it really can kind of go down to even vocal cord dysfunction as something else that these patients might have, but anxiety. So doing a PFT, if you've got somebody who's got a normal PFT, and if you even can do a pre and post bronchodilator pulmonary function testing, that's even better. And that's normal. So then the question is usually, do they have mild intermittent asthma or do they have anxiety? Then it's getting into the historical picture of, tell me when you've had your asthma. What's precipitated it? What have you been doing? What's going on? And so, if somebody where you can go back in the history and really be able to tease out the fact that, oh, wow, this really sounds like more about anxiety, more of a same way with anaphylaxis at times, more of this vasovagal effect that some people could have, then that's a little bit more likely. With vocal cord dysfunction in some teenagers, we see them on the basketball court, they're running up and down and they drop to their knees and they're inspiratory stridering and having problems. And people think it's asthma. It's like really vocal cord dysfunction, and dealing with that instead of being treated with asthma. The simplest thing that urgent cares will do will be to treat them with asthma or treat them for asthma. They're not going to deal with the anxiety. They're going to treat and treat them. And that sounds bad, but that's kind of the model of an urgent care. And so I think it behooves us as respiratory specialists to really be on our guard to look at, is it anxiety or not? So I think doing an anxiety scale, having a tool available that you could have them take to find out if they're anxious, do a little bit more of a history. Have you ever had anxiety attacks? Tell me what actually happens. Tell me where the trouble is. Asking them where their difficulty breathing. Usually anxiety is going to be, I'm having trouble breathing in. It's right here, and they'll point to right here. Whereas remember, asthma is an obstructive phenomenon. It's difficulty getting air out. They may perceive it as getting air in, but it's really they're breathing out and their wheezing occurs. So what kind of noise is made? When is the noise being made? All of those are the questions you can go through if they otherwise have a normal PFT. Okay.
Awesome. Thank you for that. I know it's reassuring and feels good that in our virtual asthma coaching program, we do talk about, we have a whole section when we talk about how to manage your asthma and how it relates to other comorbid conditions, but also anxiety, depression. So all of what you're saying is
Great.
great and makes me feel good as we, continue to educate our participants. We have a
You're
couple
doing
more
a good thing.
questions.
Okay.
We have a couple more questions. One is likely from a community health worker or asthma educator, but the question is there a place for community health workers and asthma navigators in addressing anxiety and depression in children?
Ooh, that's interesting. I'm going to put Angus back up. He's much more relaxing to look at than Q&A. That's a fascinating question. I think there is. I think if you, as a community health worker, you're going in, if you're doing home visits, looking at the aspects of the home, looking at other stressful situations that are occurring at the home, dealing with mindful, basically keying in on what can I do to help this child. And depending on the age of the child, you can work with distraction, breathing techniques, relaxation techniques, mindfulness. All of those things are simple things you can talk to that child about and help them center themselves and ground themselves rather than spinning. Sometimes is what these kids do is they start having a mild little asthma attack, and unfortunately their anxiety starts feeding back in on it. So I think helping pick up on that can be great, and then looking at their environment. Okay, if you're already well educated on what to do with smoking in the environment, what to do with other kind of pollutants, things like that. But I think looking at the stressful situation, looking at the overall mental health of the child is one of the things you could do, and I think would be extremely valuable.
Thank you. Thank you for that. Yeah, I think anyone in any capacity can ask those two questions that you said.
Mm-hmm.
Are you feeling like you're feeling down, or do you feel like you're in a position to harm yourself? I think that those are two great tools that you don't have to be credentialed. You can just be an
Right.
everyday person. So Awesome. One more question before we wrap up. What strategies have you seen help adolescents who underreport symptoms due to the stigma or denial?
Yeah. Um, Part of it is normalizing as much as you can. I mean, sometimes it's with me, it's telling my personal story, telling my family story. And because we've been very upfront in our community. So a fair number of people know about Caitlin, but, being upfront and honest about her issues and what we as a family went through sometimes just breaks down the wall. But it doesn't even have to be that dramatic. For teens, it's really normalizing the fact that a lot of people have this. Quote the fact that a third of the population can feel that they have problems. Unfortunately, there's just a study came out today showing that about 30% of pediatric patients have untreated behavioral health issues, and a lot of it's the fact that they're not recognized, or the parents can't access proper health care. They don't have the finances to do the next steps that need to be done. So I think trying, when you're seeing those patients, do what you can to decrease that stigma, normalize it a little more, and that may help them kind of recognize I do have a problem and I'm going to work on that, or I'm going to take the next steps that I need to do to help get that under control. And letting them know that if they do that, your asthma is going to be easier to treat, most likely, and we'll be able to not have as many exacerbations. All right.
Thank you so
Great
much. Thank you for
question.
that. Yeah. Very engaged group. Thank you so much. Um, we thank you, Dr. Marr, again for this insightful and engaging, very engaging presentation. Thank you all for joining us today. We hope this session has provided you valuable tools, strategies, but also awareness and information to support your practice and management and treatment of anxiety and depression in your asthmatic patients. In a few days, Zoom will email you a link to the recording, supplemental resources, and a post-webinar evaluation. Your feedback is very important to us and helps us shape future programs. Please join us next month for another Advances webinar on March 18th at 1 p.m. with Dr. Leonard presenting severe uncontrolled asthma, tailoring therapies for complex patients. With that, on behalf of the Allergy and Asthma Network, we thank you again for your participation. We look forward to seeing you in our upcoming webinars. Have a great afternoon, everyone. Thank you, Dr. Marr.
Thank you. Thanks, everybody.
Bye-bye.